So I'm going to talk about the population health record, as was mentioned, particularly enabling evidence-based public health care through this particular approach. So I've divided my talks into three areas. First, a bit about the theoretical foundations for this project. So what are we trying to accomplish here and what framework? Then I'll describe the project itself, some of the activities we've done to date and the implementations of this particular approach. And then I'll close with some discussion around opportunities for the future, areas where we're planning to go. So first of all, the foundations. Some of you may have heard of this concept or this framework called evidence-based public health. It's been advanced now for a few years. Perhaps the most seminal paper really was in 2009 by Brownson and colleagues in Annual Reviews of Public Health. But really what it says is encapsulated in this diagram on the screen, that if you want to make the best decisions in public health, then you need to bring together three different things: information about a population for which you're responsible, so characteristics, needs, values, preference of that population; evidence, and I'll get more into what I mean exactly by that, but the best available research evidence that relates to the decision you're trying to make; and then resources, including the expertise of the practitioner or others involved, and all that, of course, happens within an organizational context. And if we drill down a little bit more on the evidence, they speak about three types of evidence. And so just focusing on the top boxes here now, I'll explain the bottom in a second, but they really refer to three types of evidence. The first type of evidence is what you might call causal relationships between health indicators. So for example, we know that smoking causes lung cancer. That's the type, that's what we mean by type 1 causal evidence. Type 2 causal evidence is more about the evidence of what can we do about that. So going back to the analogy of smoking causes lung cancer, type 2 evidence would refer to evidence about what we can do to stop that smoking that might cause lung cancer. So what are effective public health interventions? And the third type of evidence they refer to in this theory or framework is evidence about how do you actually adapt and translate interventions to make them effective in a specific location. So what we might even think about as implementation science these days. And so the population health record, which I'll come back to in a second, really tries to encapsulate these three types of evidence. And that's what I'm showing by the middle row of this plot here. And I'll spend more time talking about this first step, how we really use knowledge and evidence of this type to interpret indicators in the context of existing knowledge. But I'll also refer to a little bit about how we incorporate evidence about effectiveness into this, and then also how we think about capturing the evidence about the implementation of interventions. And the bottom row here will make a little more sense to you as we go through the presentation, but this summarizes a bit of what we've accomplished. A lot of the work that you'll see, these little blue dots here or blue ovals, are meant to be indicators. So many systems provide indicators as almost a laundry list, a selection of information, but with no structure. One of the main things we're doing with PopHR, which I'll show you, is we're using causal evidence, so this type 1 knowledge, to organize indicators and help people understand what information means about a population. These second two areas I'll get into a bit more, as I said, but they allow us to also connect interventions to indicators so that we understand what you're trying to change in the intervention, and ultimately to track within a given setting or multiple settings what interventions are being used for what purposes in different public health settings. So that's a bit of a framework of the actual entire talk, and it's really based in this theory of evidence-based public health. The second theory that we lean on a little bit in this work is the theory of precision public health, which has come to mean different things to folks. I like best this definition in the top left here. So it's really about stratifying populations, and I've added the interventions piece to improve prioritization of health status and selection of interventions. So I think of precision public health as trying to find the optimal match between interventions, or at least the evidence we have about interventions, and populations. And so it's most specifically not equivalent to targeting genomic differences in the population, although some have thought about precision public health that way. But really the vast majority of the evidence we have for population health is not of the genomic nature. And so we're really thinking more about other characteristics of populations that we're trying to understand in terms of their, what would make an intervention work or not. And it's not simply targeting high-risk groups. It really is about trying to find that match between the evidence we have around interventions and the information about populations. So I'll come back to this in a second, or later on in the talk as well. But these are the two theories, really primarily evidence-based public health is at the basis of what we're doing, and precision public health also is somewhat inspiring for the work. So that's a bit of the foundation. So let me tell you a bit more about the project itself now and what we've done. So I don't need to tell anybody here that there is lots of data available to us in public health now. So things are a bit different than they were even a decade or two ago in the context of the massive amount of data that's being generated and captured that's relevant to health, and particularly public health. This is a diagram that's from a paper a little old now, almost 9 years old, but it still helps to really demonstrate on the left here, you have sort of more structured data that we tend to find in databases, the right more unstructured data, which we tend to see in all sorts of venues, but really more like text and so on. And the rows talk about the types of data that we're, so we could have data on more clinical environments, medication, demographics, so on, diagnostics. And then as a bottom part of this chart, we get into more the data that might come more from the non-clinical environments, but still highly relevant to health. And the point is that the challenge that we face now, and I think, there are obviously some challenges getting the specific piece of data you want in a quickly, timely manner, which has been shown in the pandemic, but nonetheless, we do tend to have lots of data. And the challenge really is more about how to structure and organize that data and to make sense of it rather than getting access to yet more data. The same can be said of knowledge. This is what's often referred to as a spaghetti diagram from the Foresight project on obesity in the UK that happened a few years ago. And what they're really showing here is an attempt to map out the knowledge that relates to obesity as it falls in different domains. And the arcs here are meant to be relationships between the concepts, which are shown in nodes. And so the point here is this is one condition, obesity, and the knowledge is quite profound and complex. And as we think about more and more knowledge being generated, and these could be different types of evidence, as I mentioned, type 1, type 2, type 3 evidence, it becomes increasingly difficult for public health practitioners to have all of that in their head at their fingertips as they're looking at indicators that may be talking about the population health status for a particular region. So we've got this vast amount of data, we've got lots of knowledge, and we need some help making sense of this in a public health context. Of course, there's been vast advances in analytical methods, both in terms of our computational capacity to do things, but also in terms of the algorithms that allow us to work with data. Most recently, we've seen lots of progress in the deep learning space. And that's not the only area where we're seeing great advances. We've also seen great advances in our ability to classify and structure knowledge in a more human-directed way, which can also work in concert with more data-driven approaches like machine learning. And so this refers to advances in classification and ontology, which, as people have argued, is really critical for precision medicine, and I would argue also for precision public health. In other words, if you want to optimize, if you will, the match between knowledge or evidence and data, we have to structure those in the same way if we're going to be able to find the correspondence between the two. And that requires some commitment to structure of that knowledge and how we want to represent it. Okay, so those are the three things we have. We have the data, we have the knowledge, we have the analytical ability. And so it's really in this context where people started to think about this concept of a population health record. And I can't claim to be the person that invented this. In fact, it was a paper by Friedman and Parrish, which I'm citing below, in 2010, which was really quite inspirational for me, and I think laid out the definition that really is at the heart of this project. And so notionally, what they think about is a population health record. You can think of it as an analogy to an electronic medical record. So in a clinical setting, a clinician would use an electronic medical record as a means to synthesize or integrate information about individual patients. So it pulls from multiple sources, radiology reports, laboratory data, medical notes, medications. All of that is organized around one patient. And you can go patient by patient, of course, but it brings that data together for the patient. So the population health record is meant to do something analogous for a defined population that would be under the responsibility of a public health authority or a public health professional. And so here you want to have representative information for that defined population. But you also, as they pointed out in their early paper, you want evidence about population health and health systems. And you want to be able to use that evidence to explicitly create a framework to organize the information and evidence. And so this, as you can see, fits quite nicely with the theory of evidence-based public health, which, although they didn't mention explicitly in their paper, I think was really at the foundation of some of that thinking. And the idea would be that having such a device, this population health record, would facilitate population health decision-making. As I mentioned, analogously to the electronic medical record for clinicians, it allows you to integrate data on determinants, outcomes in healthcare for a specific population. And moreover, in the context of evidence-based public health, it creates a platform for aligning information about a population with evidence regarding the population health and health system interventions. And so that's exactly what we did, even though we didn't come up with the idea. As far as I understand, we're one of the first to implement this concept on a large scale in an information system. And so this is a project that's been going on for some time now, really inspired, as I mentioned, by that 2010 article. In 2011, we were successful in Canada to obtain relatively large-scale infrastructure funding for building research infrastructure through an organization called Canadian Foundation for Innovation. That allowed us to actually hire a software development team and begin the development and the conceptualization of this infrastructure. We were then funded by both the Canadian Institutes for Health Research and the Public Health Agency of Canada to take this platform and actually put it into the field and conduct research working with public health practitioners on how to design, but also to implement this kind of a system in public health practice. And then most recently, starting in 2018, we worked with the Institut National de Santé Publique, which is the Quebec Public Health Agency, to further implement and evaluate this system within the province of Quebec. And so I'll summarize some of the highlights as we go through from this activities. But first, I just want to give you kind of a high-level view and a real schematic perspective of what does this thing look like? What is a population health record, or how have we implemented it here? And so I'm showing you on the bottom individual level data that we use primarily to measure outcomes. So coming from claims data and potentially clinical data, although we've not implemented the clinical data component, we're working primarily with administrative data for individuals. And this allows us to calculate many indicators at the individual level that then get rolled up into the population level on things like, primarily here we're focused on chronic diseases for the most part. So we're focusing on the incidence, prevalence of chronic conditions in the population. We would love to be able to measure health risk factors or social determinants in that way as well at the individual level, but we are challenged to do so by the data we have access to. So we rely primarily on area level data for those factors. Information on the built environment. We've used exclusively in a number of side projects and looking at grocery sales, retail data to be able to calculate indicators, for example, of healthy eating, and of course, many surveys that are accomplished. And so we use these data to come up with neighborhood level, area level measures of the determinants of health or health exposures. And then we use these individual level claims data, and if they were available clinical data, to capture or create these individual level indicators. And then core to all this, going back to how we organize the evidence, is something called an ontology that we use to structure all of those indicators, whether they're about individuals or the exposure they have, into a data bank about indicators, which can be made available to public health practitioners, clinicians, and the public. Now, in this project so far, we've primarily focused on public health as the main use case or users. And so there's really two things I think that are somewhat innovative here. One is that we have what I would call a real-time data capacity. So we built this essentially a pipeline or an ability to go from raw claims data and compute indicators, such as I mentioned, prevalence, incidence of chronic disease from those claims data for individuals, and then automatically roll those up into population health indicators. So that's something that has currently been done manually by a number of people with a very long lag time, and we've managed to really kind of speed that up. But I think the most interesting, and the piece I'll focus on the most in this talk, is as how we've used this evidence or this knowledge that we have, a type of artificial intelligence called an ontology, to encode what these indicators are and how they relate to one another within a causal framework, and how we use that to drive the application. And so that's what I'll spend most of the time talking about this morning. Just a few words on the kind of underlying technical infrastructure, and this is again still fairly schematic, but I just want to point out that we've put a lot of effort into creating an infrastructure that is knowledge-based. And by that, I mean we really want to keep the knowledge, which you see here in the ontologies, in a separate format or separate encoding from the rest of the algorithm and the infrastructure for the software. Now, that's traditionally done for data, where people will have databases and data marts that hold the data required for an application. But it takes a little more work, perhaps, and thinking to also manage knowledge in the same way. And we do this because we want that knowledge to be inspectable, we want it to be understandable to humans, and we want it to be easily updated and shared too. Those are the main reasons for breaking out the knowledge that way into ontologies. But this line here, for those of you that are interested in information technology, above here is our server-side components. Essentially, we have the data mart, the ontologies, and then we have a number of server-side components that allow causal exploration. So looking through the ontology, also interpreting the data mart in terms of the ontology, data discovery, semantic discovery, which simply means querying against the data using the knowledge, computing the indicators, as I mentioned, and something I'll come back to, we have something called A/B testing built into the application, where we can randomize users to see different types of presentations of information and evaluate those impacts. And then we have these application programming interfaces here that allow third-party applications, a web application I'll show you, an R API client, all to interact with all of this knowledge and information that's held behind this interface on the server side. And wherever possible, we've tried to make use of standards such as SDMX, which is a global standard for exchanging population health information, to encode that information that's shared from the server side to these third-party applications. So that's pretty much it for the IT, but just to give you a sense of the background. Now, in terms of the knowledge, this is perhaps one of the most, as I said, interesting parts of the application. What knowledge is in the application? How do we organize it? How do we maintain it? This is where ontologies are really quite helpful. And we make the distinction between domain ontologies, you see here in the green, and application ontology. So domain ontologies are representations of knowledge where the knowledge is meant to be universally true. It's not really anything specific to this project or what we're trying to accomplish. These are descriptions of knowledge about things like diseases, geography, public health, things that ought to be relevant and consistent across many projects. And so here we identify wherever possible these are domain ontologies, and we incorporate them or import them into our work or our project or application ontology, which is really more focused on what we're trying to accomplish. Is not really meant to be generalizable to beyond our project necessarily. So as I mentioned, we make use of these existing domain ontologies where they exist. It means that we're using essentially a standard of knowledge that exists, that can, something that the community's agreed upon. And moreover, we don't have to maintain that knowledge. So that really helps in terms of maintaining a system. In the public health ontology or public health indicator ontology that we maintain, we do get into the specifics around things such as taxonomies, hierarchies of indicators, for example, the prudential concepts. But a lot of the evidence, as I mentioned, particularly around causality, is encoded in this public health ontology, which we maintain ourselves, actually. The other ontologies we don't, but we expect this public health ontology to be something that's of general truth and relevance across projects. All of these ontologies then are also consistent with what we call upper ontologies, which are really ways for organizing really fundamental concepts. And the theory here is, of course, if people organize their knowledge in a way to be consistent with these standard upper ontologies, they ought to be interoperable or shareable. So that's just a few words about the knowledge and how it's encoded in the system. Diving a bit more into that public health indicator ontology, just to give you a sense of for those of you who may not have seen this particular approach or technology, what it looks like. Again, a little bit like I was showing before, these concepts here are in these nodes. So an attribute, a personal characteristic, body mass index, these are all concepts. And then the lines indicate relationships between the concepts. So these grayish lines indicate what we call hierarchical taxonomic relationships. So quite simply, a personal characteristic is an attribute, and body mass index is a personal characteristic. And so this creates this kind of hierarchy that allows us to do some type of logical reasoning about how concepts relate to one another. But we can also express other types of concepts, such as these orangish arcs here, where we can say, for example, body mass index has an effect on the risk of diabetes. So this is a way we can show that if a certain level of body mass index in an individual does have this effect, which could be interpreted as a causal effect on the risk of diabetes that could be realized as diabetes. And so again, we can have multiple types of these relationships, and then we can use these relationships, which are quite structured here and encoded in terms of logic, to actually organize and reason about the information. And so I should point out, going back to what I said at the start, this is not really a replacement for strategies like machine learning. It's really a strategy for representing knowledge where we don't have a lot of data from which to directly derive that knowledge, but we want to represent that knowledge. And so in this way, I find ontologies and this type of approach to knowledge representation can be quite complementary to more data-driven strategies for artificial intelligence, such as machine learning. So coming back to how we use that knowledge. So again, going back to what I said at the start, we have these three types of knowledge: these causal relationships, effective interventions, and adaptation or implementation of interventions. We focus for the most part on how do we exploit these causal relationships. And going back to the bottom here, you can see what we really want to do here through the concept of these indicators for these blue nodes. We want to be able to structure or organize these indicators in the context of knowledge to help, particularly knowledge on the determinants of health, to allow people understand what's happening in a population. So I'll just quickly show you a few screen grabs from the application, just to give you a sense of how it works. And I won't spend a lot of time on this, but if, for those of you who are interested, this URL, pophr-ca.mci.mcgill.ca, is operational. The interface is in French and English, and so you can switch back and forth. In the top right corner here, you can see the button allows you to do that. And we'll just go through a few of the examples so you can get a sense of how we so far incorporated that knowledge into the presentation of indicator information. So the causality graph is probably the easiest place to start, and that's this icon here to get a sense of what or how this knowledge is structured. And so this is sort of the default way that you're shown indicators about a population within the causal graph. It defaults to a concept. We've currently set that to type 2 diabetes, but you could choose a different central concept. And just to orient you, you've got sort of this causal graph in the center. You've got in the top here different views that you can go look at, so be selected. And at the bottom, you have different ways to filter the information in terms of stratification and also selection. But really at the center of this view, you can see these squares, which are these concepts I mentioned. Under each concept, you can see a list of indicators. So there's a drop-down menu here that has all the ways that we measure the concept of diabetes type 2. You can see for some concepts, such as amputation, we don't have any indicators. So we still show that concept because I think it's important, but we don't currently have a measurement for it. Where there is a measurement, the concept is a darker color gray. You can see the list underneath. Now, what we show is this is really quite a complex graph showing these relationships between the concepts. And these are meant to be causal relationships. But we simplify it by only showing the immediate upstream and downstream neighbors. That can be expanded by pressing on these buttons. And then moreover, what we try and do is overlay some of the data that we have about the population people are looking at in the concepts of these indicators. So as you can see, every concept has a default indicator, which is shown below it. And for example, the relationship between physical activity and diabetes, we actually look at the smallest geographical unit that we have. So this is an ecological correlation, the smallest geographic unit we have. And we look at the correlation between the indicator for physical activity that's selected and the indicator for diabetes type 2 that's selected. And what this is showing is that we can see a negative association by the color blue, and a fairly strong negative association. So regions where we're seeing high values of this indicator for physical activity, we also, we tend to see low values, of this indicator for diabetes. And when the line is red, we're seeing a positive correlation. So this is not meant to really, in its own right, tell people a specific answer, but it's meant to show them the patterns that we're seeing between these indicators in the population they're looking at right now. And you can, of course, move upstream. So if you wanted to click on physical activity, that essentially recenters that, or sorry, that was overweight I clicked on, and that centers overweight. And now we can see, we're now seeing the upstream indicators for what's causing or affecting excess weight. And then also you can see on the right how excess weight is affecting downstream factors such as diabetes type 2. So we can jump into other views, of course, of the data. This is a simple one where we're just looking now. This is for health regions in Canada. And there, as you can see, there's a fair number of health regions in Canada where we've calculated these indicators for. And this is showing you a bar plot. We simply have the regions at the bottom. And we've identified one region here in the province of Quebec, where I'm living, the Gaspésie-de-la-Madeleine, which tends to have, and now we're actually looking at overweight, self-reported overweight. And you can see they have a fairly high level of self-reported overweight. We can easily flip to and look at a simple summary for that region. So we're showing now an age distribution on the left for this health region. You can see that's actually an older population than the Canadian average, which is shown by these lines, and the bar plots are the specific region. You can see that down here in terms of the average age. 50 to 54 is the average age range. And we know that we have certain issues or challenges of this population, particularly a low level of active transport compared to the Canadian population, higher levels of unemployment, and low high school education as well. So there are some challenges in this population in that regard. And now here, though, what we can do is go back to that ontology to help us look at those indicators. So the ontology was being used explicitly in the background for that causal graph to pull out the arcs and allow us to look at those relationships. But now what we're also doing is looking at specifically the values of some of those factors. So again, the ontology, by selecting, this is essentially the disease view, we've called it up here. So we're now highlighting one region, the Gaspésie in the top left. In the top right, what you can see is, again, this is for self-reported overweight. You can see the Canadian average in blue, and then you can see over a number of years how that indicator has remained consistently higher for this one health region. Now, at the bottom part here, what we're showing again is we've pulled from the ontology, what are the indicators of factors that influence overweight on the left, and on the right, what are the downstream consequences of overweight? And every one of these little circles is a health region in Canada, one of those bars I showed you on that earlier bar plot. The black line is the Canadian median, and then the teal circle is this particular region. So you can see that this region has a fairly high measure in terms of sedentary behavior, interestingly, a low measure for stress, and then not terribly good marks either for physical activity or healthy eating. And then over here, you can see on the right, as you'd expect, as we knew before, there's a relatively high level of diabetes type 2, also high levels of asthma. So this is just meant to bring together a lot of information, but again, using that knowledge, that causal knowledge in the background to help organize that information and help people understand what factors might be driving other factors in this population. So far, we've implemented this infrastructure in two major settings. One is in the province of Quebec, which you see on the left, done together with the Quebec Public Health Institute, using very high resolution data. So here we're connected literally to individual level claims data for the 8 million people in the province that allows us to calculate those health outcomes. And we also have very high resolution measures available down to the health region for the determinants and risk factors. And we've been working through a number of workshops and studies with our public health partners, which were unfortunately interrupted by the beginning of the pandemic in 2020. But we're getting back on track, and I'll tell you a bit more about that at the end. The second implementation, which is the one available, which I've been showing you so far through the web application, it's publicly available. So this is a login required for the Quebec access, but for the Canadian one, it's publicly available. And here, all indicators were pre-computed. So we're not using the part of the infrastructure that goes from raw claims data to compute indicators. We're using previously computed indicators and really focusing on the ability of the application to organize those indicators using the causal knowledge. And this has information available at the provincial scale, but also down to the health region scale, which you can see on this map. And we've done a number, been using this application, or a number of different training programs, and I'll show you how we're also using that information for some of the research projects in the coming slides. So, but first, I just want to say a little bit about the challenge. I don't know if these challenges exist where you are, but certainly in Canada, we found it a challenge even just to pull together existing health indicators in a consistent format. So this is a process, again, we were driven by chronic diseases, and we said, let's pull all of the relevant indicators we can find from open sources for health regions and provinces in Canada and organize them according to our ontology. And so this was quite an extensive effort. We ended up finding over 108,000 data points at 561 stratifications, considering by sex, provinces, territories, health regions, and time. For 129 of the indicators that we identified in relation to our ontology, our indicators of chronic disease. And these came from multiple systems, some at the Canadian level, some at the provincial level, and really representing 37 public health concepts. So this was quite an endeavor, and something we call data raccooning, where we had to go and find in multiple different systems and sources these indicators. So this was really quite, unfortunately, a manual effort, but ideally something that could be automated. And what do we find for challenges there? First of all, the definitions of indicators changed over time. So even within the same organization, they would often change from one year to the next, the definition of an indicator. There's inconsistent alignment across indicators. So when they were defined by multiple organizations, the conceptual definitions were often quite different. They were also different over time and by geographic level. Some areas, indicators were pooled over multiple years, potentially as a concern about re-identification risk, but still making it difficult to combine a 3-year indicator with a 1-year indicator. And there were multiple changes to administrative boundaries, with health regions disappearing, splitting, and so on. And so all this to say is that it was really quite a sobering process to try to pull together all of these indicators. And I think part of the challenge here is because we were looking to pull together indicators across full social determinants of health as well as the health outcomes. And there really was no organization with the remit to really standardize or structure or coordinate all those indicators across those settings. Okay, so that's PopHR project. So now I'll say a few more things about where we're going for the future before leaving some time for questions and discussion. So first of all, I mentioned this very briefly before, but we were concerned by the lack of high quality evidence in the literature to guide the effective use of digital communication to communicate population health information. There really is not a lot as far as I can see. And so one of the things we wanted to do in this project was really engineer this platform we're building to allow for essentially randomized trials of presenting different types of information or information in different ways to users and measuring their responses. So this is inspired by this sort of A/B strategy that's often used in information technology companies such as Google and others, for example, where almost on the fly, they will present to you different versions of the interface. They won't necessarily tell you they are, but then they will, based upon your response, they will determine which of those interface options is in some sense better. And then they will migrate to that as the kind of the approach they use in the future. So this is very analogous, of course, to randomized controlled trials we talk about in healthcare settings. And here, what we're really trying to do is, the exposure is the information or the interface, and the outcome is how people react to that, which we can measure by just using electronic trails. We can also prompt people with questions to ask them why they did certain things. And so we've yet to fully deploy this, but this is something we're very excited about that we built into the application where we can present results to people, for example, using a different interface or using perhaps causal information in one view and not another, and really track how that influences what they do downstream. The first project we might actually get into with this is working with a health commission here in Quebec to present information more on health system performance. And so we're looking at using this application to understand, or this kind of approach to understand how people respond to different information on health system performance. So I'm going to talk about two specific areas, which I've already alluded to in the future, which we started to do work on. The first one is really using this platform I've described to help people select interventions. So this is the idea, really a conception about precision public health. Can you think about finding an intervention that's optimally matched to a population? So as I mentioned, that's this kind of second type of evidence we're exploiting here, is how effective are public health interventions. So the first thing we wanted to do was find a good partner who really understood this type of evidence. And so we worked closely with a group called Health Evidence. They're based at McMaster University and funded by the Public Health Agency in Canada. And what they do is essentially a living review of the literature, where they're going through the biomedical literature and they're pulling out systematic reviews about public health intervention. They're grading the quality of those systematic reviews and then putting it into a database that practitioners can search. And so what we said, well, let's make an interface to that database, essentially, where our system can reach out and access those systematic reviews that have been graded and organized around public health interventions. And we can try to find, as people are working in the application, so driven by the information about the population that they're looking at, the things that they're trying to do, the concepts they're looking at, we can in the background be searching health evidence and trying to find interventions that are relevant to what that person is doing and try to match those things. And so, as I mentioned, there is some challenge here in this matching because you need to have your information structured in the same way as the evidence to be able to make that match. But if we can do that, then we can present to decision makers or individuals using the application, what are those interventions that are most relevant to you? And so we've managed to implement this. We did a fair bit of work on coming up with a graphical interface that made sense to people, and of course, making that interface. And this is an example where if somebody was using the population health record application and they'd filtered the population down to be looking at females who are 60 plus, and they're looking at the concept now of diabetes, then by clicking on the health evidence tab, which you're not seeing up here, but we've added in this application, they would come up with this view. So in the background, we've already gone and searched and found these systematic reviews that are relevant to older adults who have diabetes. And we've given a number of ways that the person can then further filter. So they can filter by, I only want strong review, low SES, or other characteristics that they understand about that population. And that will further limit the systematic reviews of interventions. If they're interested in one of these interventions, they can click on that. They can see a summary, an abstract, essentially abstracted, and they can also go on directly to the health evidence site if they want to get direct access to that intervention. So this is really our first effort to try to connect that second type of evidence into this population health record so that people can almost be prompted by and make it easier to go see what is that type of, what's the available type 2 evidence or evidence about interventions relevant to condition that they're interested in. The other area we're quite interested in is really that third type of evidence, which is how interventions are implemented. So, and here we're thinking about moving towards another concept you may have heard of called a learning public health system. So how can we continue to learn about what implementations are being used and how effective they were in a real world kind of way? And one way we think we can do that is by actually having people record what interventions they implement, so in specific settings, and ideally characteristics of that implementation process. So again, going back to the bottom here of this diagram, if we think about starting with just a laundry list of indicators, we can organize those in terms of causal knowledge, determinants of health. This is the arcs here connecting the nodes. We can add our knowledge about interventions as affecting specific concepts here. These are these yellow nodes. And now we're really talking about capturing information about when an intervention is implemented, what was done, what resources were used, and so on. And of course, over time, this creates a recording really that allows us then to think about evaluating the effects of those interventions in relation to the information we have about the population. So it's really interesting that this is not done routinely in public health, certainly not in Canada. I don't think it's done in most countries. But it would be unheard of to think of a patient going into a clinical setting and the clinician doesn't record what they did to the patient. They don't record the therapy because, this is how we understand what we're doing in the real world and how it affects the patient. So the analogy here is at the population level. If we are taking actions or interventions we're putting in place, we ought to be recording those in a consistent and standard manner, again, so that we can learn in a real world way from what interventions are being implemented and how effective they are. There are standards that exist. They're still, I would say, being kind of road tested, but there's an international classification for health interventions that does have a public health component. And there are other intervention strategies and methods also that advance. And so this kind of a platform could incorporate those standards and it could facilitate the recording of these types of interventions. And as I mentioned, that could really allow real world effectiveness analysis of how implementations are being implemented and sharing those success factors across different public health authorities. And ultimately that could lead to better targeting or tailoring of interventions, or as I've described that, precision public health, and ultimately contribute to a learning public health system. So that's where we're trying to get to. And I will just close then by thanking the team. As I mentioned, this has been a large effort over many years. We've had a number of software developers, Alexis Hamel and Juffet are the two key ones, and a really amazing software engineer, Maxine Levine has been very helpful. Number of software interns as well. And then we've had a really strong team on the public health user experience side, managing the indicators, knowledge engineering, of course, and just maintaining our interaction with different public health groups as we go through different internships and projects. And so I want to thank the team that has contributed to this. Also to our funders, as I mentioned, we have a number of funding partners that have provided funding to support the platform, and then practice partners in public health and research partners, both in information systems and biomedical ontology. And then here's a couple URLs. One is actually to our website, another one to the application I was showing. And with that, I will stop the screen sharing and be delighted to have any discussion or questions.
Thank you very much, David. This was really a very, very nice presentation and totally in line with our discussions here in the Canton of Vaud at the University of Lausanne, on the importance of those ontologies in the field of public health. And also on, the Swiss healthcare systems is highly decentralized. So we really have this, issue of working on interoperable data and infrastructure rather than trying to centralize things, because it's, from a political perspective, just impossible to achieve. I guess you have something similar in Canada. So now the floor is open for questions. I see one hand. Eric, please ask your question.
Yes, thanks very much for that inspiring talk. I have a couple of questions, but I start just with one related to what you showed, actually that project to link the data that you have on population characteristics with the health evidence database. And I was wondering, I mean, that's an area, sort of applicability of interventions to a certain given population. I mean, that's an area also of sort of judgment, and you need the information, of course, on the population characteristics, but also on the inclusion criteria of the studies that are integrated into that piece of health evidence or public health evidence. So how much information in the health do you have on the side of the intervention, the evidence on effectiveness of intervention, meaning the data that you have in the health evidence database? I understand that's not actually a full text database. It's a sort of extracted data from the studies. So is it really possible to match it with population characteristics, or do you still need to look into the individual studies and then decide whether it's applicable to the population?
Thank you for that question, and that's that really is the rub of that, if you will, the challenge, the real piece there. And so we've done a couple deep dives, you could say, in that question. So one area we looked at was actually influenza immunization. And we very much tried to structure as much as possible. Really, if you want to really do this well, what exactly, as you're saying, what is that level of description you need, and is it there? Is it supported? The short answer is no, it's not. And it's interesting. We've worked very close with health evidence on that. I mean, I can't say that's a universal proof, but in that particular area, we could not get to the level of precision that we really needed in terms of the details that were described, the way it was structured, particularly around, as you were saying, areas that require a fair bit of judgment in terms of the characteristics of the population where this was implemented and how it relates to the specific population. Part of the problem has been that health evidence was much more expressive in what they recorded, but they didn't really find a good use for it before we came along. And so they'd really simplified down to some extent their manual description. Since working with us, they've actually, over the last 10 years, they've actually brought in more sophisticated machine learning and natural language processing into their process, actually, which has allowed them to gather more and more detailed information. And they do keep a free text description, but it's not always easily to parse that in real time either. So this really is one area which I think, if this is going to happen, we need to pay more attention to, which is, how do you, and the challenge, of course, is they're trying to go right from free text. There's virtually no structure in PubMed for them to pull on. I mean, there is a bit if they can get the full text article with some of the encodings, but people spend a horrendous amount of time doing a lot of good time doing research, and then we publish it, but we turn it back into this free text thing that really is not terribly well structured and not really well suited to computer manipulation. And so that really is a challenge. I haven't completely given up hope on that one. I do think there are probably happy mediums there that we can find, but it's going to require some degree of standardization on the evidence side. And I should also say, on the information side, a lot of the characteristics that are important for implementing interventions deal a bit more almost with the public health infrastructure in a region. How many resources are available? Do you have the right type of nursing skill? These things are not often systematically recorded. So I think we've highlighted limitations on the evidence and information side, I would say. I don't think this strategy is fundamentally flawed, though, because in a sense, this is what we're all doing in our heads, right? We're always taking this evidence from the literature and trying to figure out the generalizability question in some sense.
Exactly.
Here, it's not like a scientist trying to generalize for everybody from their study. We're in a public health setting, we're very interested in a specific context, and we're trying to figure out what fits here. But it really is a challenge to get the information and the knowledge in the right format, exactly as you've put your finger on.
Thanks very much.
Thank you very much. I give the word to Marie-Annick.
Yes, thank you for your presentation, which was very, very interesting, and I really enjoyed it. Well, I have one question relating to the data you use. You said that you used claims data for identifying chronic diseases or any diseases you're surveying, but you compare these indicators using claims data with population characteristics such as BMI or I don't know any other characteristics, and these concern the entire population, not the only population who had contacts with the health system. So there is two levels of measurement, which is the population level and the claims data level. So how do you reconcile these two information, in fact? How do you get it also? Because claims data is easily to get, but for the population side, which is your sample, how do you get this population information?
Thank you for that question. That is a challenge. As I mentioned, I think there are relevant area level concepts you'd want to measure at the area anyway, but for a lot of the determinants of health, they are at the individual level, and we just don't have good measurements on them. So it's interesting you say claims data are easy to get. It took us about 5 years to get access to these data under our but you're right, they're all in one place. So once you get access to them, they're there and they're well structured and so on. So it's fairly straightforward. I will point out, though, it was interesting. We tried to access pre-calculated indicators, as I mentioned, though. It was much harder because they were all over the place and they've been done in different ways and so on. But you're right, the determinants data are really the challenge. And so the best we could do is drive it down to the smallest spatial area possible. So that's really what we tried to do. There are a number of existing repositories of these types of either raw data or indicators. Wherever possible, we tried to reuse someone else's indicator because our goal here is really to make something that is sustainable. So just like we tried to reuse knowledge, we tried to reuse indicators where possible. We did find a lot of them, but ultimately, as you point out, we have to be careful about the type of inference we're supporting for people. So if you go back to that causal graph I was showing you, it really is ecological, right? What we're doing is we're driving down to the smallest area possible information we have about risk factors and outcomes. We have done some experiments looking at to what extent individual relationships, as we can measure them, hold up at ecological levels, at different levels in our data. And, they're more or less robust, as you would expect, per chronic diseases. Now, again, you have to think carefully about how this approach might translate to other types of conditions where you have, less lag time, less stability in the indicators. Infectious diseases, for example, might be more challenging, and you might want to be much less reliant on some of these area level indicators. Although I would say even in the pandemic, we've seen that area level social determinants explain a lot of infectious diseases that we're seeing as well. So, but I think your point is a good one, is that we do have to be careful, and we do try to communicate that to people quite carefully so that they're not misunderstanding what they're seeing in terms of the information as it's being presented to them. One quick add-on to that, though, I would say is that we have engineered the system in such a way we could pull in clinical data as well. So if we did have access to electronic medical record repositories, for example, or individual level information, there really is no technical limitation to us calculating indicators of social determinants from those individual level data as well. That would be possible, or even having kind of compound indicators that span in a trajectory way risk factors and outcomes in individuals, and understand those. So you can really almost think of new types of indicators. And just going back to the point around federation, we've actually had two major public health reports come out in the context of the pandemic, pointing that this approach of trying to centralize data and have sort of reporting hierarchically of indicators where it's just not feasible and it's not working. and we need a new strategy. We need a more distributed approach where the disaggregated data remain locally, but we have a sort of federated architecture that allows us to compute those indicators in a consistent way, in a comparable way across regions. And so that is another area that we're looking at trying to support with this project, is to what extent can this become a way, a best of both worlds in a way, where you can centralize access to large central databases like statistics databases that we might have and make those available to smaller areas, or at the same time creating a tool where local public health regions can upload their own data and make that available within a data governance model to external regions to come look at and calculate indicators from. And so that's what we think is probably the direction of the future. But again, a lot of that has to do with data governance, a little bit of that with technology, and a lot of that with culture as well.
Great, thanks a lot. Other questions? On my side, maybe a common name. So we have in Switzerland the Swiss Personalized Health Network Initiative, which aims, it's a distributed system, decentralized system aiming at, creating interoperability across university hospitals, so that they all are able to extract their data in an interoperable way within a highly secured infrastructure, IT infrastructure and architecture. So that's what has been going on since a few years now. Of course, it takes a lot of time. Every hospital has its system, its governance, and then it takes time to put everybody, to have everybody agree. Also, all the security aspect, data privacy aspect is quite tricky. So the discussions about the governance is taking a lot of time and energy. But I think that once those issues are solved, as you say, technically, I guess the solution is not so difficult. The technical solutions exist, just need to invest the right amount of money, at the right time. But I'm really convinced that it is important to have a public funding for such initiatives and not to let, the governance of those data to only private actors. I think that would be a mistake, but that's current reality, that private actors have much more data about people than do the public ones. I don't know what you think about that.
Certainly, as we think about social determinants, yeah, a lot of that data. In fact, as I mentioned, one of the major activities we did was we were, as we dug into chronic diseases, it became clear from the beginning, but what was clear is we didn't have any indicators on healthy eating. We had virtually no indicators on what people ate. We had a survey that was done every 10 years or so at the province level. That was just not really what public health needed. So exactly as you said, who has that data? Grocery chains have very detailed data, often linked to loyalty cards. And so we, in fact, worked with one large grocery chain with loyalty data to access the transactional data that we could, again, not link to individuals within our data model, but could drive down to relatively small spatial regions in terms of, basket purchasing profiles and so on. And, allowed us to come up with what we think was a reasonable indicator of healthy eating. But how is that done at scale, I guess, is the question, right? And that comes back to the governance issue and how you relate to private and public information holders. And just to say, I wouldn't want to make the impression, it is true there are technical solutions that exist. And so if we had the governance worked out, we could implement those solutions. But I think we need to be realistic within public health. Do we have the expertise within public health to implement those systems? Do we have the evidence as to how we would want to use those systems effectively? I think that's actually lacking at some level. I think also the training. I don't know about in Switzerland, but certainly in Canada, we're doing our best to train people in this area. But, a lot of the people that we see, they get excited about this. They want to improve, diagnosis of lung cancer by analyzing imaging. And I think that's a great thing. But there's a whole plethora of interesting problems in public health that will require people with this kind of a background to be excited about public health solutions, both to, implement these systems, evaluate them, build the evidence base. And so I do think we need to kind of keep pushing, in addition to the data governance, to on the research in this area and the training in this area, so that we are ready to exploit this for public health benefits.
Yeah, fully in line with you. Actually, I was discussing with our dean this morning. We have a computational biology department, very strong, we don't have a public health equivalent. So we're very strong on, personalized oncology, but we're not strong on, data science in public health in terms of investment. We don't have the corresponding investments for public health, and we're trying to fight for that. Let's see how we can convince our, local and federal authorities. But I am really convinced that there is a high potential to really get to, producing, close to real-time evidence to inform, public health decisions and interventions and policies. What is effective, what is less, and what do we choose to do? Yeah, exactly based on that.
I agree, and these things are complementary. So I mean, I
Exactly.
don't think it's either or.
No, of course, I don't claim we should stop the others, but we should also do it for public health, basically.
Yeah.
Okay, I'm just looking if I see some hands waving. Eric again, please go ahead.
Yes, if I may, with a quick second question. You mentioned in I think that was the second last part of your presentation, the platform for evidence-based monitoring. So that idea of presenting information in different ways on an interface and then measure outcomes in a quasi-randomized manner. So you mentioned that you would be interested in the understanding and beliefs, or even change in action of people. So what type of people do you mean? Is it decision makers in the field of public health? And what's your or lay people who might not always be in positions to take decisions on the public health level? And what's your experience with regard to the availability and interest of the let's say the potential participants in taking part in these kinds of experiments?
Sure. Yeah. I mean, so you need a sufficient number of people, a sample size, essentially, to do that effectively, right? And so this is a bit of the challenge, is that the people we've worked with, and just to go back to your question of who the people we worked with, I mean, we've worked with, we thought we were building this more for surveillance folks, but in the end, that's not really who we were building it for. Surveillance people want to get their hands on a big database, and they want to use R, and they want to analyze it. So this was really the two user groups in public health that were most interested in this were, one, we're decision makers. So people who wanted a big picture, really what is going on in my region? What do I think about that? The second was really people who were trying to explain surveillance information to somebody else, often outside of the public health setting. So in the education network, and then they're trying to explain why it's important, how these things relate to one another. So those were really the two of the major use cases. I think the surveillance people wanted access to the R API or the ontology, where they could pull the data out and look at things. And they still found it quite useful. So back to your point about the randomized testing, it's really most useful where you've got more people that you can get those numbers and get those more atomic interactions. As the farther you get from the change of the interface, the harder it is to attribute some behavior to what they saw. So, we will be deploying to a larger scale of regions. As I mentioned, one of the things we're looking at is health system performance, and how do you present information on health system performance? And that work will have a general public as part of the user group as well. And so there we can, for example, present a very simple way of saying it. You present independent information about, performance of a system in some way. And another view, you could sort of connect those dots, if you will, and show why they're driving, or what we think is driving, what different performance metrics. And then you could ask the person for some kind of a response afterwards, for example. That would be a simple way, or even just see if, time on the site, how much time do they spend looking at it before they move away? If they spend longer on it, we can often interpret that as them being interested or looking at it. And then you could, so that's to your answer. You do need sufficient numbers. And so it's probably best used with the general public or in deployments where you have a reasonably large number of users.
Thanks.
Great. Thanks a lot. I see that it's noon, so it's time for us to end this presentation. Thanks a lot once again for taking the time. It was really very, very interesting presentation, and very much looking forward for potential further interactions, because it's really very much aligned with what we're trying to do here in the Canton of Vaud, and maybe there is also some way to collaborate at some time on this fascinating topic of population health record. Thanks a lot, David, for joining, and have a nice day.
Thank you very much. My pleasure. Nice day to all of you as well.
Thank you. Bye-bye, everybody. Bon appétit.